And ladies and gentlemen, it's a great pleasure to be here. Portugal, as you know, is famous in England for two things, or three things actually, and one is Ronaldo, the other is Jose Mourinho, and the third is the excellence of the work and the hospitality here. So it's a great pleasure to be here. Where does cardiac MR fit into the assessment of cardiomyopathy? I think it's in some ways regarded as the new kid on the block, but any technique, whether it's nuclear, whether it's CT, whether it's MR, has to deliver on three key things, because that's what matters to the patient, that's what matters to the clinician looking after the patient. What are you going to do about prognosis? How can we implement an effect and make a difference there? What are we going to do about morbidity? Quality and quantity is important. If a patient is suffering, your fancy tests have no consequence. And more importantly, as doctors, we're often reactive. The patient comes through into the emergency room. But think backwards. What can we do to prevent the problem? The best way to win a war is to never fight it, as Sun Tzu said in 600 BC. And we're in the era now where there are lots of classifications. There's lots of ways of assessing cardiomyopathy. We have the European classification based on the morphology, and echo provides excellent imaging for this. What's the function doing? What's the right ventricle doing? What's the left ventricle doing? What are the valves doing? You have physiology with excellent advances, speckle tracking, etc. To look at that. If we look at the American guidelines, we also have the added component of genetics. So you can classify according to acquired, genetic, and then mixed. And we're seeing an increasing number of cardiomyopathies and processes and a number of ways of classification. So where does cardiac MR fit into all of this? Well, I think that the limitations that we've realized are with genetics 5 years ago, 10 years ago, all you need to do is a blood test, you'll have the results. And now we see that there is a marked disparity between having a genotype and seeing the expression. Family members with the same gene mutation, one will have a DCM, one will have an ARVC, others will have HCM. There's a lot of downstream changes that are occurring. Secondly, accurate diagnosis is crucial. Unlike in ischemic heart disease, where clearly diagnosis is important, the added component here is the implications for the family. If you have a member with HCM, they have 1 in 2 chance that their siblings may be affected as well. Their children need to be screened. So there are ramifications. There's emotional ramifications, there's the implications for jobs, mortgages, all of these things. And so getting accurate diagnosis is important. And so, as I will talk in this presentation, I believe the incremental role of cardiac MR is multiple. I think it represents the gold standard for the assessment of biventricular volumes and function. You've got to get the diagnosis right. What is the wall thickness doing? There's a big difference between something that's 12 millimeters and something that's 15 millimeters. The classification is different. Secondly, and we'll see this in much more detail, I believe the real strength is the opportunity for in vivo tissue characterization. There is no other technique that will give you the depth of information without recourse to biopsy. Thirdly, and this I think is the most important point, diagnosis, 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 as William Osler said. That underpins the whole of your management, your risk stratification, the way that you approach the patient. And as we'll see, we're now starting to see the emergence of prognostic data, and we're now starting to see the role in guiding your therapeutic intervention. Should this patient have a CRTD or an ICD? And if so, where should you be placing your CRTP leads, for example? But to come back to the patient, I'm going to show you 4 cases. The history in all of these could be exactly the same. Shortness of breath, dizzy spells. And with echo, although we'll have some additional physiology data, I think this would be where we would be left in some ways. You've got concentric hypertrophy in the first case, you've also got hypertrophy in the second. You've got concentric hypertrophy in the third case, and you've got hypertrophy in the fourth case. And yet the pathology in all of these cases is extremely different, as we'll see. And there is a common theme to these. They all present similarly, but what's going on? How does cardiac MR help in the evaluation of these patients? The strength relies upon its comprehensive information in one test, so you have the assessment of the anatomy, accurate diagnosis. Is there a dilated cardiomyopathy or not? If someone has very good function, you don't need an MRI scan. If someone has very, very poor LV function, You don't need an MRI scan, you could argue. But often in the borderline cases, that's where the key is important. The poor echo window, very important to know that. Also, we tend to focus on the left ventricle, but actually, what's the right ventricle doing as well? Becomes very important. Secondly, from the cardiomyopathy perspective and the incremental value, the opportunity to look for fat infiltration, so T1 weighted imaging. Is there ARVC, for example? Is there alcoholic fat replacement? Inflammation, I think, has made a major stride. So is there acute inflammation, and that's relevant in a patient presenting with possible myocarditis or acute infarction, but also looking at sarcoidosis. Is the disease process active or not? Do we need to give steroids? In someone with the active phase of sarcoid, do we need to be thinking about a defibrillator? It directly impacts on your management. And then the other important aspect is the ability to visualize scar tissue. And here for those of you that may not be familiar, we give a contrast agent, gadolinium, which is taken up in areas of fibrosis. So it's an extracellular water marker and has different patterns according to the pathology. So in the infarction, it's always the subendocardium that is affected. Whereas as we'll see in many cardiomyopathies, it's the midwall, the subepicardium, that is more prone to be involved. So first thing, your volumes, your function, and again, I won't dwell on this, you'll all be familiar, but it is the initial and most important thing. What is the right ventricle doing? What is the left ventricle doing? So no geometrical assumptions, accurate assessment of the wall. And then secondly, when we do go on to give gadolinium, it's the patterns that we see that are important. So the infarction, the subendocardium is always affected, and it can affect one or multiple coronary territories. In dilated cardiomyopathy, it's the mid-wall fibers that for some reason are mainly affected. In hypertrophic cardiomyopathy, we have thickening of the heart muscle with a patchy extension of fibrosis. And then in myocarditis, again, similar pattern to dilated cardiomyopathy, but often much brighter signal in the context of an acute history. Sarcoidosis, we have a joke that if the heart looks funny, the GAD looks funny, it's probably sarcoidosis. And then amyloidosis, where you have this very bizarre pattern of so-called zebra striping with a dark blood pool, this circumferential pattern of late enhancement that affects both the left ventricle and the right ventricle. And I think the importance is succinctly brought out here. You can have all of these techniques and you can have a lot of wisdom, but the scar tissue has an impact. It has an impact in terms of heart failure development. It has an impact in terms of arrhythmic development. And so we'll focus on a few cardiomyopathies, which I'll present. So firstly, dilated cardiomyopathy. This is a patient who's on the transplant list with us at the moment. As you'll appreciate, this chap is very, very breathless. So he's got marked left ventricular dilation, he's got marked right ventricular dilation, he's got discoordinate function, he has a very restricted filling pattern with marked biatrial enlargement, very poor long axis function. This guy's in trouble. And when we look at the hearts of patients like this, we know that they too have fibrosis. They have a lot of interstitial fibrosis, but they also get increased replacement fibrosis. And the pattern, as we've seen earlier on, is very much mid-wall. It's not subendocardial, it's mid-wall, subepicardial, often affecting the septum, but can also be seen in the lateral wall. And so some years back, we looked at a cohort of 90 patients with heart failure, 63 of them with a diagnosis, clinical diagnosis, based on angiography of dilated cardiomyopathy, so unobstructed coronaries. 27 patients we also looked at with known ischemic heart disease, known infarctions, and known coronary disease, and then we compared them to 15 normals. And what you see is that all the ischemic patients with known infarction have a subendocardial pattern of enhancement, normal volunteers, no gadolinium uptake. What was interesting was in the dilated cardiomyopathy population, where you see three patterns. About 60% show no enhancement of the myocardium, and then about 13% of patients who are said to have a dilated cardiomyopathy have a pattern of enhancement that's identical to that which is seen in the infarction, and yet they have unobstructed coronaries. So what's going on? Well, almost certainly here you have the wrong diagnosis. These patients have either recanalized, had an embolic episode, or spasm. And depending on the extent of the infarction, it's either the primary cause or represents concurrent bystander disease. But it highlights and demonstrates some of the reasons why luminography on X-ray angiography has such a poor predictive value for adverse outcomes. And then correlating with what our pathologists regularly see, that mid-wall pattern of enhancement. Here an extreme case where you see it affecting all the septum, extending into the lateral and the inferior walls. And how can we be sure? Well, here is a sad case of a lady who had a pre-mortem scan, the pattern of enhancement seen in vivo, and then sadly she passed away, a post-mortem heart demonstrating almost identical delineation between what you see in vivo and what is demonstrated ex vivo. What are the implications? Well, multiple. Patients with fibrosis are much more likely to show adverse remodeling. They're much more likely to show a lack of responsiveness to beta blockers. So when we looked at these patients over a period of 2 years, patients with fibrosis or without fibrosis are much more likely to demonstrate some improvement. With fibrosis, their ejection fraction is much less likely to improve. Here a case example. This is a 48-year-old gentleman, smoker, who presented with acute chest pain, tightness. His troponin was elevated. His ECG showed ST elevation in the lateral leads. So he's got an acute coronary syndrome. He had an echo which demonstrated really poor LV. So everyone was kind of expecting quite extensive disease. He'd also got a strong family history. Here we're looking at the two-chamber view, and again a very poor LV. He had an angiogram, and sure enough it confirmed coronary disease, but he got a 60% stenosis in the circumflex vessel and nothing else. And yet the left main, the LAD, the right, they're all clear. And that degree of disease doesn't correlate with the level of dysfunction we're seeing. So something else was going on. He was referred for an MR scan to see if he'd recanalized or something else was going on. And you'll see the images in terms of function confirming the poor LV. And when we give him gadolinium, yep, he has an infarction correlating with that acute presentation, but it's small. That amount of infarction does not account for the level of dysfunction that this gentleman's presented with. And when you probe the history, it transpires that he's drinking more than his cardiologist, and what he has is an alcoholic cardiomyopathy with concurrent coronary artery disease. And reassuringly for him, when he cuts back on his alcohol intake, there was an improvement in function. So again, a very clear, tangible demonstration of the applications, the incremental value. And I think we're starting to see now a shift in paradigm away from just using your angiogram in making the diagnoses to really the fact that both from a prognostic perspective, from a clinical perspective, you need to know what's happening at the tissue level rather than just at the coronary levels if you're going to make a clear diagnosis. This is based on Felker's original description. And then risk stratification. We know that patients with ischemic heart disease, poor LV, benefit from a defibrillator. The jury is a little bit more out in the context of dilated cardiomyopathy, where there are several trials demonstrating a probable benefit, but there is still some inconsistencies. Work from Johns Hopkins, from Zhao Lima's group, and Nazarian has demonstrated that where you have mid-wall fibrosis, you're much more likely on the EP study to have inducible VT compared to those patients without fibrosis. The greater the amount of fibrosis, the greater the likelihood. Secondly, and this is work from our group, from Rabiasamol, in patients with fibrosis, if you follow them up over time, they're much more likely to have adverse outcomes that all-cause mortality and unplanned cardiovascular hospitalization compared to patients that don't have any fibrosis. And an important question is it an all or none, or is it a progressive thing? And the evidence is that the greater the amount of fibrosis, the more likely you are to have one of those primary endpoints. What's also interesting is that traditionally, we base our stratification on volumes, on ejection fraction, and compared to those, the initial data at least suggests that the presence of fibrosis or the amount may be a better discriminator than our conventionally held dogma of ejection fraction, the yellow line. This has also been demonstrated by Catherine Wu very elegantly in patients with an ICD. Appropriate discharge and survival are much more affected by having fibrosis than in patients that don't have it over a fairly well substantiated time period. Scott Flan, looking at patients with dilated cardiomyopathy, patients with fibrosis, again, a much worse outcome. So we're seeing a consistent trend across multiple studies. It's not a good thing to have. And then in terms of guiding treatment, beta blocker therapy, so where you have fibrosis, those segments are much less likely to be responsive. In other words, we need to be thinking about more aggressive therapies. We need to be thinking outside the box for different therapies. Secondly, resynchronization therapy. It's a great treatment. We've heard lots about it. but 30% don't respond. Why is that? Is it because the leads have been put in the wrong place? Is it because the technique is wrong? Or is it because the actual theory is wrong? MR offer incremental value. Well, it's useful for looking at the dyssynchrony, but actually echo does that very well. So I would stick with echo for that. Where I think it adds value is in understanding that 30% non-responsiveness. One of the key reasons is that if you place your LV lead in the coronary sinus near the lateral wall, and that's an area of high fibrosis or scarring, you're either going to get poor capture or you're going to induce rhythm abnormalities in those territories. And so routinely now in our cohort, all patients undergoing CRT will have an MR scan prior, and where there is fibrosis or scarring in that lateral wall, we'll advise the operator wherever possible to try and deviate the lead away from that territory to try and improve the outcomes. And preliminary data suggests that that shows a benefit. And then thinking differently. It's no good just having another way to do angiography, another way to do what nuclear and CT can do very well. What else can we do? And I think prevention and anticipation is really the future in terms of the electrical side of things. So looking at flow patterns and trying to anticipate remodeling. Here looking at flow in the right atrium and remodeling the heart to try and understand where the stresses are and using a treatment to try and reduce that. If you can do it in a research setting, look at treatments, you can expand that to a much wider cohort. Secondly, SCAR and EP, where you've got fibrosis, that's a focus for arrhythmia, because reentrant arrhythmias can occur in that area. And so it makes sense that if you can develop a three-dimensional map of where your fibrosis is, superimpose it onto your electrical map, this has utility in improving the outcomes from your subsequent ablations, VT ablations, and in reducing procedure time, improving the safety, reducing the radiation burden. So these are all important avenues for identifying ventricular arrhythmic substrate and improving outcomes, providing incremental value. Myocarditis, again, viral infections. This is a young army recruit who's 24, who's had acute chest pain, troponin rise. He's had a recent viral infection, but there's concern. His ECG confirms ST changes, his troponin's elevated. Everyone thinks he may have an infarct, but could he have myocarditis? And then in the background, could he have been taking cocaine? He's an army guy, so this has ramifications for his livelihood as well. So when we scan him, we demonstrate a pattern of mid-wall enhancement there, seen here as well. And that's a very typical pattern in the context of the history for acute myocarditis. And the range of sequences will enable you to identify the scope and extent of that, of those changes, and whether the disease process is active or not. So here, active inflammation seen in the anterior and the lateral wall of a patient with quite severe, extensive disease. And this has been validated now in several studies, but particularly nicely by the Stuttgart group with biopsy validation in the left ventricle. And there is preliminary data to suggest that the location of enhancement in their cohort, in the Stuttgart cohort, may also reflect which pathogen, the herpes virus or parvovirus in their cohort, may be the cause of that myocarditis. And depending on that, looking at outcomes as well. So practical applications. Some beautiful work from here. Again, a nice case study showing a patient with ST changes inferiorly, his angiogram, unobstructed coronary arteries, the MR scan demonstrating both acute inflammation and mid-wall enhancement. So a practical example. And when we looked at 60 patients with new onset chest pain, troponin positive, unobstructed coronaries, and we scanned them within 3 months, you can see a whole range of patterns. So here, again, patient with recanalization, an infarction in that territory. Here an example of acute myocarditis in someone presenting with shortness of breath, chest pain, a dilated LV. So in about 65% of patients, the MR within that setting is able to identify a cause of which acute myocarditis is the commonest, but then you see some with recanalization, some DCMs and Takotsubo. And in 35%, where although you're not picking up a clear diagnosis, importantly, you're excluding significant myocardial infarction fibrosis with a resolution of 1 to 2 grams. And then in hypertrophic cardiomyopathy, again, you're all familiar, asymmetric hypertrophy, increased interstitial fibrosis, myocyte disarray, carries an increased risk of sudden death, carries an increased risk of heart failure, and affects 1 in 500 of the population. So here an example of marked asymmetric hypertrophy, left ventricular outflow tract obstruction, demonstrated there with typical SAM, the apical variant, the inverted spade sign, marked thickening there. So what you have here is an opportunity for accurate diagnostic evaluation. Which section of the myocardium is affected, and echo, for all its strengths, isn't always able to pick up the areas that are thickened. You often have a confusion with septomarginal trabeculation. Having very good delineation of the wall thickness means that you have an opportunity for really working out accurately what the thickness is, and that has major ramifications for the family. Do we need to screen their kids? And then, what is the role in risk stratification in guiding treatment? Well, in the diagnosis, in hypertensive disease, you may also see hypertrophy, but it doesn't typically tend to cause any degree of fibrosis. And then, our clinical challenge is this, that 1% of these patients are at risk of sudden death on an annual basis. 10% will progress to heart failure. We've got good risk factors, VT, VF, LV outflow tract obstruction, but they have a low positive predictive value for working out who needs an ICD. They have good negative predictive value, all our standard parameters, but very poor positive predictive value. Blood pressure, non-sustained VT, syncope, all of these things. And so there is a need to enhance, to refine the way that we stratify these patients. And so what is the role of fibrosis? So reflecting what you see in vivo, you have patchy fibroses. You can affect any portion of the heart, but most commonly the areas that are most thickened. The mechanism is probably a combination of things, but microvascular ischemia is going to be an important cause. And then you tend to see a lot of fibrosis in that territory, for example, that's thickened. Another example. And then it can be patchy, as in this case. There's good in vivo and ex vivo validation. So here a patient that underwent transplant, demonstrating good delineation between what's seen in vivo and what's demonstrated ex vivo. And recently, when we looked at 217 patients with a condition, the presence of fibrosis again shows a consistent trend with other cardiomyopathies. Patients do badly when you have fibrosis, and importantly, the more the amount of fibrosis you have, the worse the annual risk. This is at 1 year, 2 year, 3 years for the primary endpoint of major adverse cardiovascular events. If you then break that down into heart failure and arrhythmic events, the data in this study demonstrates that patients with fibrosis are much more likely to develop heart failure. And again, the greater the amount of fibrosis, the greater the annual risk. For the arrhythmic endpoint, on univariate analysis, it shows a significant trend, but on multivariate, it's not quite significant. And so what's happening now is that a number of multi-center studies are in place to look at much larger patient populations, longer outcomes. But what is clear is that in work by Bruder and colleagues from Stuttgart, that the presence of fibrosis is a highly predictive parameter for cardiac death or all-cause mortality, and often better than some of the conventional parameters of 1 or 2 risk factors. So, important, useful, definitely for diagnosis, it's there. For risk stratification, I think we still need some more longitudinal multi-center data before we can say it's ready for prime time. And then briefly, amyloidosis. The heart muscle's thick, but it doesn't thicken. So concentric hypertrophy, often with a pericardial effusion. There are good techniques to look at it, to look at amyloid in other portions of the body, such as the SAP scan in the liver and the spleen, but it's a poor discriminator of cardiac involvement. And with MR, as we've seen in the initial slides, you have this distinctive pattern, circumferential enhancement, a dark blood pool, zebra striping, and that reflects the binding characteristics. When you look at the electron microscope of these patients, you'll understand why it is that these patients have a 50% mortality rate within 2 years. The myocardium is almost choked by these fibrils. And what's happening in this situation is the gadolinium is binding to the fibrils rather than to reflect extracellular fibrosis. Examples here. So bright enhancement, dark blood pool with validation. For those of you that are doing scans, again, whenever you see that pattern, it's very important to make sure you adjust your inversion time to demonstrate that it's not artifact and a genuine abnormality. The sensitivity, specificity is good. One of the problems is if you pick up that abnormality, you're fairly comfortable, but who are we missing? So work is still being done in multi-center settings to identify early detection, what does it mean? Sarcoidosis, non-caseating granulomatous condition, important cause of sudden death and pacing requirements. Patients often will also develop a burnt-out dilated cardiomyopathy type phenotype, confirmed on biopsy in this example. And looking at Roberts' series, there are a number of areas that are classically and commonly affected. So most commonly your left ventricular lateral wall, your RV subendocardial surface, your papillary muscles, but as you'll see there, it can affect any portion of the heart. And biopsy is relatively limited here. Most of our biopsies tend to be right-sided, and yet the disease is often left-sided. So your pickup rate can often be as low as 20% in these patients. What we see on MR correlates with what's demonstrated in vivo and ex vivo. So you see patchy areas of change, but typically in those same areas demonstrated in Roberts' series. And using a range of sequences, which area is affected, what is the disease process, is it active or not? So in this patient there's extensive enhancement, but the main disease activity is in that area. This patient goes on to high-dose steroids for 3 months, 40 milligrams of prednisolone, directly impacting on their management. And the current data suggests, and this is work from Ray Kim's group, that CMR, in addition to your algorithm, appears to improve your sensitivity dramatically by a factor of 2. Briefly as well, overload cardiomyopathy for patients with hemochromatosis, with thalassemia, you get a major iron burden, and using T2 star parameters that are unique to MR, you can correlate how much iron there is, and this has now been validated with biopsy samples and post-mortem hearts, and use that information to direct your chelation therapy. The mortality rate in the UK for this condition has dropped from 7 per 1,000 to 1 per 1,000, purely as a consequence of introducing the T2 star MR-based sequence to guide your chelation therapy. And non-compaction, what some people describe as the cardiomyopathy of the new millennium, where you have your hypertrabeculation, your deep intratrabecular recesses, your intrauterine arrest of the formation of the walls. And this is my favorite slide. This is a gentleman who's in his 70s. He's been followed up in clinic for 30 years and told he has an alcoholic cardiomyopathy. And every year he comes to clinic and he says the same thing: I don't drink. And of course every alcoholic denies how much they drink. And everyone says the same thing. A new doctor sees him every year in clinic: stop drinking, you'll be fine. But I don't drink. And so he's referred for an MR scan, and very much to everyone's surprise, he turns out to have myocardial non-compaction. And for the first time, everyone believes him in clinic. Then yes, he doesn't have an alcoholic cardiomyopathy. Unfortunately for him, after being told that it carries a risk of sudden death, increased embolic episodes, arrhythmic episodes, and heart failure, he gets so stressed he starts to drink. But that's another story. And this has been demonstrated again with the incremental value from here, work from Anna and colleagues here, demonstrating the utility, the added value, the incremental value, combining your echo, combining your MR data with excellent histology showing the trabeculations, your endomyocardial fibrosis. So every technique has its strengths and limitations. I hope I've shown you some of the strengths, but it's also important to balance that with what are the downsides. Access is clearly an issue. You can't take the MR scanner to the bedside, or at least not yet. Cost is obviously an issue. It is more expensive, but I would argue that it is cost effective in terms of the downstream utility of tests that you avoid, and also by getting accurate diagnosis, avoiding patients being on lifelong therapy if they don't need it. Training takes longer. Some of the physics kind of dazzles us. Dudley Pennell, one of my colleagues, always says that the difference between him and the junior fellows is that he pretends he understands the physics, whereas the junior fellows can be honest and say they don't understand the physics. There are certain patients with contraindications, with pacemakers and such things, but we are now starting to see Medtronic, St. Jude preparing and having MR conditional devices. So that problem is being tackled. There is this very rare, very unusual problem of nephrogenic systemic fibrosis, and so we avoid the gadolinium contrast in patients with a GFR of less than 30 unless there's an overwhelming risk-benefit ratio. And in practice, it's very rare. In all the years that we've been working and in our follow-up, we've not seen this, but it is reported. So who should be scanned? I think the no-brainer is patients with a poor echo, patients where the etiology is unclear from the initial history and investigations. I think where you want to assess the severity, know how bad it is. For screening of family members, are their children affected or not? If you want early response to treatment. and where you want to look at, is there a systemic disease process, particularly, for example, in sarcoid. And so we come back to our case examples. There's the last 3 slides. Shortness of breath, dizziness. What is the diagnosis? So the first one, hypertrophic cardiomyopathy, hypertension, okay, no replacement fibrosis, and then these 2. So this one turned out to be amyloid in spite of good LV function, the circumferential enhancer, and the other one, when you look at the other imaging, the contrast images, hypereosinophilic syndrome. So I hope I've demonstrated to you that we have valuable data that's the gold standard for assessment of function, wall thickness, in vivo tissue characterization, and importantly, the role in diagnosis. I thank you for your attention.